yes, by the time it's ready. Okay. I'll call Shivlal sir, please. Sorry, sir. You are a seasoned person, so I'm calling you just like that. Okay. He's a great man. He said, in the Google form, I have completed everything. Immediately, I opened up the exercise section. I opened up the case submission. Just because Google form is filled, I cannot accept. No, because I know the pending list is there. Confidently, sir, did you complete? The criteria for getting graduation is completing the exercise, submitting the case. He said, I will complete, sir. That word told me, okay, he is determined. He is not taking for granted, because he made one request 4 months back. Sir, is there any situation where if 60 or 70% is complete, you will give a graduation? I said, no. Sir, that's where I got that doubt. Otherwise, I wouldn't have got that. What she would have thought? No, 150. If I finish 140, they'll allow. They shouldn't think. No. So, thank you, sir. Thank you for coming. Right? Because why I asked him? No, every time I ask, he said busy. For Facebook, I'll see his photograph. Roaming here and there, lecturing everywhere, speaking great topics. Then he has to find time for ODD also. No. Thank you, sir. Welcome. The stage is yours. Please come.
Hello. Thanks a lot, sir. Actually, Matt Abraham, he has done a study and he came to conclusion that 85% of the time when people are presenting, they are nervous, and rest 15% are just lying. So, it is about 10th and the 11th of February 2024 when a IDA program was there in Vadodara. And I heard from someone that Ramesh Selvam is coming for some program. I never heard the name actually. So somehow I went there, and what I realized that the different questions, the different queries I used to see in practice, and whenever I asked to the, learned fellows, there are no convincing replies. Like, in whole of the dentition, one first molar which is completely abraded, and there is no reason. There are the group of teeth which are badly fractured without any accidental trauma, and there is no reason. Right? So everyone is just going with a symptomatic dentistry, what I used to say. Right? Whenever there is some issues, and they are just correcting those all issues without knowing that why they are there. And that was the lecture where everything what I used to see, and I was just laughing that, how this person know that I am facing these all things day by day practice. But there were so many people who were facing same, right? And he hit very badly, I will say, when it's come to occlusion, because whenever I am putting some crowns, there are some, marks, then I used to rub them with the burrs, what most of the people used to do, right? So that is how, I came to the kind of journey of this occlusion-driven dentistry, which really completely changed the perception of practice in dentistry. And I try my best to encourage lot of people to know about that, if they don't know about that, and do the practice in that manner. So I started this journey, but I was not that sincere, I will say, with very humble. Actually, it was the 10th of February 2026 when sir asked me on WhatsApp that, by what level you are, completed your exercise. I knew that he on platform that it is 15% only. I am talking about, I joined in 2024, I think, and by the 11th of February 2026, it was 15% only. Then he pushed me, and I reached to the 55% in next couple of weeks. And then I said that, no, they will consider me because I already crossed 50%. Right? So then he said that there is no, excuse, you have to finish it. I said that by 80% they will accept. Anyway, before a couple of days he said that, you filled the form, but still exercise are left. I with confidently said that I will finish, don't worry about that. And on that day, I finished all the exercises. So this is what about my journey to enter into the occlusion-driven dentistry. Very honestly, if I say I have not done much cases, but I am very much that it is a concept which is scientifically proven by the legends, Dr. Vasant sir, Dr. Selvam sir, Ramesh Selvam sir and Mala madam. So I'm very thankful to them that they triggered me to do these all things. So directly come to my case. It is a case with the ODD FMR equilibration plus restoration, right? A patient who reported with the chief complaint of severe pain in left lower region, right? And food lodgement in left upper posterior teeth. Some TMJ tenderness was there and click was there, but it was not that severe. No symptoms, but very mild signs in muscles with a mild tender lateral pterygoid and sensitivity of posterior teeth. This was the complaints from the patient side. On the examination, we could see the deep abfractions in 3-5, which was more or less pulpal involvement. Patient had the severe pain. That was the chief complaint. Generalized facets were there. Occlusal dimples were there. Open contacts in 2-6, 2-7, and the incisal edge where we could see into the upper and lower anteriors. So a case of atresion and the mild effraction, apart from third quadrant 5 and mild TMJ, it was treated with equilibration and the composite. So this is how it was the, on the initial examination where you can see the considerable amount of the occlusal wear, right, with the lower anteriors and the maxillary anteriors treated. So this is how it was upper anteriors, where you can see the considerable amount of attrition at the same time in lower anterior, and more or less all the teeth having mild or moderate kind of the abfractions, especially into the 3-5 and the 4-4 it was more, right? So this is how at the overbite overjet. These are the close-up extraoral picture, smile, close-up. And this is what the mirror image of the first point contact into the second quadrant, 4. And most anterior contact was into the maxillary anteriors. This is how the face bow was taken. And these are the extraoral photos. If you see, these are the preoperative pictures with the pathologic groove function onto the right side, and same onto there was the non-functional interferences also onto the left side. So when it's come to treatment planning, of course, the first thing was to just eliminate the chief complaint of the patient. So we went for the root canal treatment and followed by the periodontal treatment. And directly we gave to the patient the DASA, deprogrammer, which most of the time, whenever I am absolutely clueless, I used to give the DASA actually. And most of the people are very happy. They are saying that no, everything is okay. Right? So this was the actually chart where we are going to go for the, composite restoration into the maxillary and the mandibular anteriors, and rest of all the posterior teeth will go for the equilibration. The 1-8, I think it was there, which we planned to remove, but patient was not ready for that, so we chopped it off, and it was not into the, we are not leaving any chance of interferences. This is how it was onto the articulator. Mock-up done using direct composite onto the cast only, and the next, this thing actually we more or less we skipped this. Ideally we have to go for with the diagnostic wax-up, which was not done, and test right to the patient. So when we showed the intraoral photograph and the scans, then in the co-discovery part, patient was ready to go for after root canal treatment, and patient opted for the treatment. So we made the equilibrium jig at the desired VD from the articulator, and static contact refined, and then there was the dynamic interferences corrected. So 1-3-2-3, 1-1-2-1, and the lower canine to canine built with the composite in this case using the transparent silicone index, and again EQ done and dynamic contact checked. Follow-up done at the 2-week, and we gave the DASA into the maintenance. We are calling the patient initially for every week, and then every 3 months, and then every 6 months. That is the protocol what we are going to follow. This is what the mouth equilibration photo with equilibration jig, right? And these are the post-treatment photograph where we build the central incisors and into the canines. Lateral incisor actually left. In lower anteriors also we built the composite and we got the good contacts. This is how it was, the closed smile. These are the static contact which were overlapped with the blue paper and dynamic with red. This is how it was, the extraoral pictures. And these are the comparison of pre and the post of pictures of all the sides with the on the left side with the MIP, left functional and non-functional, where all the interferences were there at the pre-op pictures, but they eliminated into the post. This is how it was there onto the right side. And these are the old records. This is how we celebrated. And this is how it was the first day when I came here. And I am really very thankful to these 4 legends who transformed the life actually of the dental practice. And I hope that they will inspire 100 and 1,000 of the people in India. Thank you. Thanks a lot, sir, to be into my life. Basically, love used to be happen once, but professionally I fall in love with perio, and I am very passionate about the periodontal and the peri-implant surgical procedures. But it was the occlusion who made me to fall again into the love. So thank you, sir, and thanks, ma'am, for being with us. Thank you.
Thank you for falling in love again, sir. Thank you. So 100% you completed at last. Okay, see, he was testing me whether they'll allow for 60%, 70%, 80%. Okay, so with this we'll move on to the next presentation, Dr. Vipin Das. So welcome, sir. Great, please come. So we met in an IDA. From there the journey started. He was supposed to attend an IDA, he missed, correct? Oh, was that the story? Okay, fine. Then you made it a point, like he joined the next time. So with this short background, due to lack of time, I can say 1,000 things about everyone here. So welcome, sir. The stage is yours, please. You love buttermilk in between. Angel told me something is wrong, so she is giving buttermilk there. So whoever wants, please have it. When we give something, you should understand what is ahead of it. Okay? So because we know the plan, no? So we are telling you, better don't say no, you'll feel bad after 1 hour. Okay? Right, better take it. Yes, sir.
Yes, thank you, sir. A very good morning to all. Actually, I have to say that I'm that kind of person who snap the wax patterns, wax carvings with the left hand from the artistic girls and the boys in my batch and submit to the staff with my right hand. So from that kind of person, now when a patient comes to the chair, I always look for abrasion. Whenever there is a diastema, then I look for any kind of functional interference. And whenever any canine attrition sees in the patient mouth, I always look for what is happening to the patient. So I would like to say that this is actually a guiding light for my entire dentistry. So with that background, I have to start. So myself, Dr. Vipin, I'm a reader in a KMC Dental College, Calicut, Kerala. So my patients with a 77-year male patient who was a lottery agent, complaints of multiple missing tooth and inability to chew food. So in the initial examination itself, there was missing tooth, root stem, FPD, which was loose, and some was treated, and there was a mobile FPD and abrasion on 3-4, and there are patient is actually not able to chew for the last 1 year. So this is the pre-op OPG, and pre-op CBCT is taken. So to start with, the pre-op vertical height we have taken with the arbitrarily for the guidance of implant placement. So TMJ examination was done. There was no clicking and grating, no gross deviation. Everything was fine. Comprehensive muscle examination was also fine. And the treatment algorithm we planned was total extraction and implant placement, and finish the case in centrifugation. So this is the implant placement. And from here, my second workshop comes. So my ODD journey starts from here. So after that, we put the healing screws, and we planned the case in multi-unit abutment, and we checked the parallelism and the scan body for digital analog. From this was the one issue we faced, how to do the vertical dimension in these kind of cases. But I don't know what I have done right or not, but I did dorsal method with this scan body in the mouth, and fix the vertical dimension at this point. So this is the scanning I have done, digital impression, and the resin trial done digitally. And this was the occlusion. I personally checked the guidance and all, everything was fine. So this was the static and dynamic contacts with the resin trial. So at this point, I treated this case as a normal full mouth denture case. So I started taking this Facebook transfer from this point, and centric relation bite is taken, and lab is asked to write for BICS trial. So when the BICS trial is articulated, and it is again checked for guidance, static contacts. So BICS trial with the contacts on the articulator. So when the BICS trial come from the lab, I again check the bite with the equilibration plate in the mouth, and again the scanning is done to verify the contacts. So this was the final static contacts, and the dynamic contacts, and the bite. So this is the functional post-op occlusal contact I achieved. And this is my OD journey. It started from here and ended up in a functional contact. So this was the patient testimonial. Actually, I dedicate this testimonial to sir, and it is. So thank you, my ODD team, Dr. Vasan sir, Ramesh sir, and Malavi sir, ma'am, and Vijay ma'am. And not only these pillars in the mouth, and all the supporting staff of the their clinics and all, they have done a tremendous work to actually upgrade my knowledge in the even articulation, whatever thing happened in the entire journey. So I would like to thank the entire clinical staff also. And not the least, my ODD 6 batch. And I would like to thank Dr. Sauda also. She actually came a long way from her place to my place to discuss the cases, and actually that actually ignited actually the courage to finish my cases. Yeah, she's like that only. So I stand here. Thank you all my ODD team, and thank you once again.
Thank you, sir. Thank you for attempting something new. So you can see, no, once that principles are there inside, you design your own thought process. How well it's going to be perfect, all those are next discussions. But for a full mouth implant, complete digital, where you wanted to bring everything into this concept. So learn the formula. Formula is there in your, you apply. If it is successful, let us know. If you fail also, let us know, so that it helps us to take this knowledge to the next generation. Hope you all understand what I'm trying to explain here, okay? So it's very difficult for surgeons to learn ODD. Okay, they just cut the condyle and leave it somewhere. They don't even care. And we are telling them to see into the marginal ridge, outer buccal incline of the marginal ridge, like irritating term for a surgeon. Okay, surgeons doing ODD is a great success. Either they should have quit surgery, or they are very passionate about occlusion. Okay, so thank you for that presentation, sir. So please call Dr. Sharmila ma'am. Sorry for the small glitch here, and she is also very meticulous. In the sense, she doesn't need any help. She just finishes everything on time. She is an on-time person in everything she does. Okay, I'm very happy to welcome you, ma'am. So happy. You are an inspiring person personally for me. Please take over the stage. You be that side,
Yes,
no?
yes. Good afternoon, everybody. I mean, everybody has thanked enough to all our mentors,
Go to president.
but this journey has just started. We have a lot to learn, and this is just the beginning of a tip of an iceberg, I feel. My journey for occlusion started because I'm a periodontist, and since I was in college days, I was only told that everything was blamed on trauma from occlusion. But in spite of asking anybody, everybody, who's who in perio, I never got an answer as to what are you supposed to do. We used to see young patients, middle-aged patients, good oral hygiene, vertical bone loss, and we just had no idea what to do about it. So, and there was, I mean, we were so busy with our life that it was not possible to do any course at that time. But I'm glad that I joined Dr. Sir Vasant Sir's academy, and still a lot to learn, but at least we are going somewhere. I would like to present a case of additive rehabilitation case, FMR done with restorations, crowns, and composite equilibration. So a 63-year-old female patient with complaint of food. She's my patient since last 15 years. I have done her implant almost 15 years back and done a couple of bridges. Her implant crown would also always become loose. She would always be loosening of the implant crown. And then she had not come to me since some time. And when she came to me, I realized, oh, I can treat this case differently. She had sharp margins on the parietal surface of upper anteriors. She had complained of foul smell from the mouth because there were a lot of gaps which had occurred in the posterior teeth. She was unable to chew her food properly. Medical history was not significant. She did complain of occlusal headaches, occasional headaches, and neck stiffness, but there was no temporomandibular joint was normal. Patient was educated to go for all the records, the ODBA test, the comprehensive examination, and budget time frame were discussed, and patient gave me a consent that she'll come a number of times because I expected that I will call her a couple of times before I can finish the case. So these were the case details. Almost many signs of occlusal disease were present. This is her picture. So as you can see, this was her, so is it clear?
Yes, yes. For you to look like that.
Yeah. And is there a marker or something? So as you can see, her 1-3 was the implant crown, which used to keep getting loose. She had a couple of old bridges in her mouth. She had incisal wear. She had occlusally. This was the MIP in right side. This was the left side. She had a deep occlusal palatal facets. I can't see actually. She had deep palatal facets. There was old crowns, which were, there was a hole in the crown on the second quadrant. And you can see even in 3-6, she had a occlusal wear. So it was, in all, I realized that, I can treat her differently. I did not want to do any additional crowns. I wanted to finish it with composite and equilibration. So I did not do any additional root canals or crowns. We just restored with whatever that was already there. This was her overjet overbite. She had a deep bite. Now this is her protrusive. Oh, can I start the video? Press this one only? Yes. You look into the laptop. Yeah. Yeah. So as you see, in a protrusive movement, there was slight deviation of the jaw. This was her. So this is what. Yeah. This was the right side. So you can see the wear facets also on where the teeth were gliding. These are the static, the pictures, but the videos are can let you know how the occlusion was. This was the palatal wear, which can be seen, extensive palatal wear. I'm sorry, I did not have a picture without the marks. I had one, but this was her OPG. This implant was placed almost 15, 20 years back. It's an ankylose implant. This was her profile smile. Patient didn't have any problem showing me her the picture. You can see that her face was very tense. Her muscles were, masseter was also, she was quite tensed. This was her profile smile. We did all after the comprehensive examination, we did all the steps. We took the Facebook records. The CR bite was fabricated. At first, I gave her a deprogrammer to wear for a few days or probably a month. After that, I called her for all the other records. And she was quite comfortable with after giving her the deprogrammer. And you can also see, I really like to take this picture every time I do a CR bite, that the jaw really goes behind, and you can really see the difference. Then so many times the patients in this step only say, oh, we are already feeling better. This is all the Facebook assembly. This was how I did my upper articulation, lower model articulated with CR bite. I got the first point contact in 3-3 as I got it on the cast also. Then after I removed the posterior segment, I realized that it was a case 4 scenario. So I had to do an additive. I could not do any equilibration in this case. So I decided a vertical where I could manage the posterior space, and decided the vertical for this patient. This patient was also particularly very, very sensitive. So little bit of height, here and there, and she would complain that, no, it's very high, it's very high. So this was a case 4 scenario after removing the posterior segment. So we decided to raise the, these are all the, so we decided to take the bite at -5. This was a lab form that I had. We decided the mock-up at -5, and we got a mock-up done from the laboratory. This was the static points that I got on the mock-up, and then we decided to fabricate her temporaries. This was an old crown that was removed, and there was a lot of food lodgement and all, but I still did not need a root canal. I managed it with a composite filling. We fabricated the temporaries using an Ora temp. So these, the temporization may not look very good, but I was quite excited to take the pictures and put it on. So these are all the temporizations of the lower. And while doing the contacts, while doing the equilibration and taking the points on the paper, the lower anteriors, as you see, I have added little bit with the Ora temp, so it was not very strong, so it was going to break off. So in my next picture, you can see that so I achieved the anterior coupling was achieved with the temporaries. And this is how, while doing this, some of the material broke off on the incisal edge because it was not. So this is, then I started with equilibrating started my upper temporization. I did a lot of composite filling on premolars, and I got a composite build-up on the palatal, upper palatal surface, and anterior coupling was achieved with upper and anterior composite build-up. This was the final, after the final restoration, this was in final MIP. This was the patient's, the open mouth. This was the right MIP, this was the left MIP. This was the right functional. This was the left functional. This was the protrusive. I managed to give her a canine guidance occlusion. This was the upper palatal and upper palatal view. This is the lower palatal view. This is with the points, and I actually achieved lines in the front, which I don't think is very clear here, but I managed to achieve dots at the back and lines in the front. This is also her post. This is her post-op compared to. Okay, these are all videos here. So this was the pre-palatal view. This is the post-palatal view. This was the pre-open bite and the post-open bite. This is the final anterior coupling and the initial anterior coupling. So I managed to get it to case scenario 3. This is the occlusal upper and lower final. And this is the patient's post-op. Patient does look happier, and it has made a difference in her musculature and face. This is the final OPG. So I've given her a night guard, and I'm going to give her a DASA, and she'll be recalled for maintenance every 3 months, 6 months, and twice a year after that. These are all the various pre and post pictures. And difficult roads lead to beautiful destinations, and I'm sure we all are on one of them, and we may not be as where our mentors are, but at least we are trying to go somewhere. Thank you very much.
Thank you for this entire perspective. That palatal picture is striking me very hard. That palatal picture, very nice.
I
said like that occlusal marks, with, that was nice. Anyway, that itself is nice. You don't have to feel bad. I'm making you happy. Okay. Great. Good to see you in this journey. So, next will be another great person is going to come here, right? Okay. I have to just make him a call, sir. Have you finished? That's all. He says, yes, sir, I'm on it. That means you shut up, I know. I understood everything in the hands-on itself. I know the content. Let me handle it. Why do you want to poke your nose inside? That is how I feel whenever I call Stalin sir. Because not even a single doubt also. Whatever he sits there, he'll learn. And the best part is, he has helped many students along his journey. That is something I love about. Because I love sharing unconditionally. And seeing another person doing the same, that too nobody knows. Only when you put in slide and say here, we know that Stalin sir is behind so many people's success. Thank you for that, sir. With this introduction, you can start your presentation.
I just want to tell you that I don't know any the major personality except Dr. Lakshman because he is my colleague when I studied BDS. So our Dr. Ramesh sir told me that I have helped many of our students. This is mainly because the help that I got from Dr. Lakshman and Dr. Arif and Dr. Murugesan. All those persons are my batchmates. So when I entered into my first year BDS, I have studied in Tamil medium and I entered into that English medium BDS. There I didn't know anything. So I had to get all the information from my batchmates only. So Dr. Lakshman and Dr. Arif, all those persons has helped me a lot. That's why I have continuing that I am continuing that same thing to our colleagues also. That's why. And this is the case for complete addition. This is the thing. I want to tell you one thing. This patient has come to me before 5 years, and I have neglected that patient to treat because That time he came for full mouth rehabilitation. Then I told him that if I want to do the full mouth rehabilitation, then I have to do the root canal for all the teeth. So I am not ready for that, and I neglected that case, and he went to some other clinics. So, but after coming into our academy, I have learned how to raise the vertical and how to do the full mouth rehabilitation without doing root canal treatment. So after learned that, suddenly after 2 months, I have joined here. That after 2 months, he came to me, and that was my luck to treat that case and present that case here in front of you. Oh, yes. So dentists are the physicians of the masticatory system. This word given by Dasan, I didn't know that other than the reparative dentistry. So the root canal treatment, crowning, and even ortho treatment, and all those things, the implants, everything I did, but I don't know much about the full stomatognathix system that is taught in our academy. So after I have come to our academy, and I have known that I have the responsibility to be the stomatognathix specialist, and to treat the patient to have a harmony between the TMJ, because the occlusion, all those things starts from TMJ, and the occlusing surface of the teeth, and the neuromuscular complex that is surrounding the oral cavity. So everything should have the harmony. That principle I have known and understood through our academy. Then I have treated this case. So in the case history, already I have told that the patient has the worn out dentition. So for the past 25 years, this patient was suffering with sensitivity and inability to chew properly all the foods. So that's the main chief complaint for these patients. But he didn't come for the treatment for all the time, because he needs cost-effective treatment. So I have taken this case, telling that I will do the treatment with less charges. So he came and accepted for all the treatment. So the past dental history revealed the extraction of 4, 6 and 3, 7, 25 years back. From that day onwards, he has the same problem, inability to chew with sensitivity in all the teeth. Yes, the clinical features are the 4, 7, that is already treated with the root canal treatment, and it is failing with mobility, and there is pain on percussion also. So missing 4, 6, 3, 7, and attrition, wear facets, and all over the dentition. Then fremitus I felt in relation to 3, 4. Then exostosis because of the increased load over those particular teeth. Then end-on-end bite in the left quadrant. So this is the preoperative photographs. So you can see the worn-out dentition. The last view is protrusive. This is the occlusal view. This is MIP and latrosive views. So when I ask him to smile or show his teeth, only the lower teeth exposed. You can see that. So this is the preoperative OPG. So after doing that ODBA test and the equilibration chart filling and every procedures, he has understood that his dentition needs some restorative treatment and full complete addition treatment, and ready to wear the dasa and all those things, because first I have some confusion whether this patient is having some difficulties in chewing with TMJ problem and muscle pains. Even after giving the dasa also, in previous to giving that dasa also, he didn't complain anything. So after completing the procedures, I have understood that the TMJ is normal. Then I have carried out the procedures. So this is the result of the ODBA. The main difference between the CR to MAP is 1 mm only. And I have known that the preoperative occlusal scheme, there is more interferences in the functional and non-functional and protrusive movements. Then I thought to correct all those things. And the equilibration is not needed for this case. So only the addition, only the vertical rise I have to decide. That's the main thing. So these are the treatment plan. Only the 2.7 I have written as C here, but that is wrong. The composite restoration or nothing that has been done in 2.7. But in 1.7, the composite restoration was done. So deciding the treatment vertical. So these are the points I have carried into my mind. The anterior coupling with the positive overjet and overbite, and minimal invasive procedure. So I have selected the PFM crowns, then the anterior guidance and the group guidance. The anterior guidance mainly in the right side and the group guidance in the left side, because in the left quadrant he has the end on end bite. So I didn't want to take risk to make it into anterior guidance. So I have given the group guidance up to the first molar. This is the mind map. There are some modification in my treatment plan because of the retention problem. So I have splintered the crowns in incisor, central incisor and lateral incisor, and splinting of canine and first premolar in all the quadrant. Then the root canal treatment that was done accidentally in 3.5, because in between the procedure, the patient developed more sensitivity in relation to 3.5. That is the only tooth I have done root canal treatment. So rest of the teeth, I didn't do any root canal treatment for this case. Then implants, he accepted the treatment for implant in relation to 3.7 and 4.6 region. So in 4.6 region, I have to go for cortical basal implants, because I have to give the final treatment, final crown immediately. That's why I have chosen that. But in 3.7, I have taken time for 6 months. So I have gone for conventional implants. So this is the procedure. This one we have learned from our academy. So this is the lab instruction I have given to the lab for wax up procedure. So the vertical dimension I have increased up to 4 mm. So with that, they have done the wax up and given to me. Then I took the index and gone for a test drive with the acrylic crowns, and showed it to the patient. With the test drive, he was happy to have the vertical rise. Then suddenly after that, I went for crown preparation in all the teeth, and with the same wax up, I have asked the lab person to give me the PMMA crowns. Then I have fixed it and checked the occlusal scheme and confirmed the anterior guidance in right side and group guidance in the left side, and all the static points I have achieved. Then after that, I have removed the anterior crowns with the PAP rule for final treatment. The anteriors up to first premolar I have removed and take the bite again and gone for face bow record, then articulation, then trial, then the final restoration in the anteriors. With that, the posteriors are having the temporary one. With that, I have checked the scheme and made sure that the anterior guidance and the group guidance in the left side and protrusive guidance also. Then I went for posterior restoration. So this is the occlusal view with the posterior restoration. So again I checked the scheme, everything went well. This is the marking. So see the canine here, the 1-3, that is good in that is good when I give this crown, but after 6 months there was a fracture. This is the dasa I have given after completing the procedures. He was wearing it. This is the radiographs. In 4-6, I have given 2 radiographs. One is having linguotomy implant in relation to distal one of 4-6, but the next one is having the straight one, that is also the corticobasal implant, that is rough surface. Because after 6 months I have seen some mobility in distal one. Then I removed it and placed the one with the straight angulation with the rough surface implants and give the crown. This is the pre and post operative views. So here you can see that the canine 1-3 is showing some fracture, but after 6 months there is no other complaints, but that is mainly because the patient didn't wear the dasa. This is the markings I have got after completing all the treatment. In 3-7 also I have given the crown on the implant, and 4-6 having 2 implants, but in the mesial one is having the occlusal mark, because I don't want to give the occlusal load in the distal one. So this is after completion. This is protrusive, right laterusive, then left laterusive. You can see the group guidance in the left and anterior guidance in the right, and nice protrusive guidance. Yeah, I want to thank our mentors, because they are striving hard to make us stomatology specialists.
It's a very complex case in the sense it's not easy to handle. The only thing is, when the protocols are clear, any complex case can be handled. Of course, you will have challenges. So when the challenges come, you need to know, you have to review and see what is happening at the background. Thank you, sir. Thank you for this presentation, sir. So now I call upon Dr. Shalini for a presentation.
A heartfelt thanks to my mentors for giving me this opportunity. So without any delay, let me move to my case. So my case involves clinical diagnosis, occlusal equilibration, implant rehabilitation, prosthodontic treatment, and endodontic management. So my patient name is Selvi. She is 47 years old. She came to a clinic with pain in upper right back tooth region. She did not have any kind of medical history, but her dental history revealed that she has multiple RCT treated teeth and a missing teeth also. Though patient did not have any kind of TMJ or muscle symptoms, the clinical photos revealed that she had occlusal diseases. So she had lower anterior wear and multiple heavily restorated teeth and the missing teeth also. So since patient's chief complaint was pain, emergency management was prioritized, and emergency access opening was done on the first visit, and intercanal medicaments was given for the symptom relief. And this is the RVG and this is the clinical photo. So with the pre-op photos taken on the first visit, we had a detailed consultation with the patient and her husband. The patient was educated about the FMR treatment. We told that the problem is not only limited to the single tooth, but it involves the entire stomatognathing system. So patient accepted for the FMR treatment, and following that comprehensive examination of the stomatognathing system was done. The ODB test was taken. So these are the ODB test details: upper and lower pre-op impressions, face bow record, face bow, and dorsal bimanual manipulation was done. Load test was done, and load test results was negative. and this is a CR byte record. So after composite indexing and after the byte record. So the first point contact recorded was in upper 1.6 and lower 4.6. So considering patient's privacy, I didn't post her full face photo, but she was concerned with her aesthetic, concerned aesthetically, so I've showed her frontal smile alone. This is the right oblique smile and the left oblique smile. This is the nose to chin views where the patient was in the rest while saying Emma and while saying F. So coming to next to the intraoral photos, this is the MIP, open mouth, upper lower occlusal, maxillary aesthetic view. This is the sectional view, and this is the mandibular aesthetic view. This is the sectional views of mandible. Anterior coupling view, that is the overjet and overbite. Lower incisal edges, MIP right, MIP left. Right functional, you can appreciate the see the interferences on the both sides, which has been indicated with an arrow mark. Right non-functional, left non-functional, and right protrusion, left protrusion. So the next stage is equilibration on model. So this is the equilibration chart sheet. This is the original chart sheet what we have recorded while doing the mock-up cast equilibration. So these are the photos with models with bite, without bite, and the vertical at CR was plus 2.5 mm. Vertical at MIP was 0.5 mm. So this is the CR2 MIP slide. This is shown in the incisal table view. So the first point contact matches both in the model and in the mouth also. So 1.6 and 4.6. Die cutting. And this is the vertical after removing the posterior segments, which was minus 1 mm. The anterior-most contacts was 2.3 and 3.3. Mind mapping chart. So the model trimming has been done with the teeth in relation to C and X. So we decided to keep the tentative vertical as minus 1 mm and start the equilibration of the arrow mark teeth. So the reason why we kept the tentative vertical as minus 1 mm was the canine contact was happening in case scenario 3. So the desired anterior coupling was achieved. So we decided to keep this as a tentative vertical. And the model equilibration started with a 40 micron red articulating paper, and these are the contacts. So first adjustments was done in 2.6. And after reducing, still more adjustment was needed on the desired tooth. So on the adjustments was done. On the second tab, we achieved all the contact on the arrow mark tooth. But here we encountered another situation where the static contact we achieved after equilibration on the arrow mark tooth was 0.5 mm, but previously what the tentative to vertical we have fixed was minus 1 mm. So we decided to keep this 0.5 mm as a tentative vertical, and but this demanded a canine buildup in the anteriors, that is in 3.3 and 4.3, which will improve the anterior coupling. So the canine buildup was done to get static contacts, to plan the dynamic and lateral torsion on the either sides. Composite in 3.3 and composite in 4.3. And this is a final thing of upper and lower cast with the static contacts and with the dynamic contacts. You can see the dots in the arrow mark teeth, that is the static contacts, and the lines, dynamic contacts, the anteriors. So this is the wax up lab instruction form, and these are the wax up mounted cast after the from the lab after the wax up. And this is the right MIP, right functional, right non-functional, right protrusion. The interferences has been eliminated. This is the left MIP view, left functional, left non-functional, and left protrusion. So the during treatment photos. So at first the RCT was done in 1.6 and the 1.7 tooth was structurally damaged and it was fractured. So we decided to remove that 1.7. Implant placement was done in 3.6. This is the bone assessment X-ray. This is after the implant placement. So RCT was done in 1.1 and 4.1, and re-RCT has been done in 2.1, and core buildup was also done. This is a RCT and re-RCT procedure photos, X-rays, and the FEC cutting photos of both upper and lower. So equilibration in mouth started with the help of the equilibration plate, and you can see that dots. which was created by the lower teeth, and the first contact which is happening in 2-5. Same wise in the lower, the 3-1 which is touching the plate, creating the contact, and 3-5 giving the first contact, 3-1 touching the plate. So equilibration was done in 3-5, parallelly the plate was adjusted, and then after the first adjustment you can appreciate the static dots in the anterior of the upper and lower views. And the second adjustment was done in 2-5, and simultaneously the plate was also adjusted. So after the second adjustment, we got all the static contacts on the desired tooth. This is the upper view, and this is the lower view, sectional views. So prosthetic phase 1, temporization phase. So in that, the temporaries fabricated from the wax up was trialed in the patient mouth, and the adjustments was done with the plate inside the mouth. The adjusted temporaries with dots along with the natural teeth, both upper and lower. So the composite restoration in the anteriors, lower 3-1, 3-2, 3-3, 4-2, 4-3 was planned for like composite in the anterior. So silicone index was taken from the wax up, and accurate transfer of the plant anatomy was done with the help of silicone index and placed in the mouth, and the composite work was done. This is the final finished composite, and this is the anterior coupling view. The anterior, lower anterior giving static contacts with the upper temporary and upper anteriors. This is the final temporary photos, upper and lower occlusal, guidance, right functional, right non-functional, left MIP, left functional, left non-functional without no interferences. Canine guided was given in the temporary phase also. So prosthetic phase 2, permanent phase. So these are the lab instructions for the permanent crown and the implant crown. So for the permanent work, posterior was scanned first. We removed all the posterior crowns. Antetemporary was luted in the anterior because already the system was in CR. Posterior scanning was done with the help of a verticentric bite. Vice versa for the anteriors also. Posterior big strial was luted and the anterior temporary was removed. Anterior bite scan. These are the permanent photos of the crowns. Intraoral post-op with occlusal marks. So this is the final photos of the permanent crowns with occlusal marks. Each and every tooth has a static contact and the canine showing the dynamic contact. Upper, lower. So these are the post-op intraoral photos. Upper occlusal, lower occlusal. MIP, open mouth, maxillary aesthetic view, sectional views, mandibular aesthetic view, sectional views, and anterior coupling view, widget and overbite. This is the lower incisal edges view. Pre-op MIP right, pre-op post-op MIP right. Right functional interferences are seen, but on the post-op, we have given a canine guided occlusal scheme. Right non-functional pre-op and left right non-functional on the post-op. This is in the protrusion, right side, protrusion, post-op. Pre-op left MIP, post-op left MIP. Interferences eliminated, given a canine guided occlusal scheme in the functional view. Non-functional, left non-functional. Protrusion. So this is the extraoral photos of the close-up photos of the patient's smile. You can appreciate the strained muscles over the pre-op side and post-op giving a relaxed muscles. And this is the post-op right oblique view and left oblique view. So at this moment, I thank this patient for her trust in us, for the coordination and consistency she showed throughout the entire FMR journey. And a heartfelt thanks to Dr. Vasant sir for giving valuable clinical insights, for his unwavering support. Not least, Dr. Vasant sir, Dr. Ramesh sir, my guru. Sir, your teachings are beyond textbooks and clinical procedures for me, and I find myself so fortunate to have been learned under your guidance, sir. Thank you. That's all. Thank you.
Thank you, Shalini, for saying the same words as I taught you. She has to meet me again, no? So whenever she has to do something for that, okay? Great. Great. So the best part is our photography has improved a lot. All the photographs, whatever you see is, it's our own photographs. Okay, so that is something she has learned everything, and she is going beyond also. I'm happy about that. Okay, so with this, we call the most important person in this entire hall. Okay, he's been behind me for the past 1.5 hours. When will you call me? When will you call me? When will you call? My makeup is going, my dress is going. Huh? Welcome, Pradeep. God bless you. Come, come. I don't know what teachings he is going to bring now, because he has his own philosophy. ODD philosophy is one of the philosophy which he is going to follow. He has his own Dr. Pradeep philosophy will come. Okay, anything surprise comes, don't be tensed. You can start.
Thank you.
Thank you, sir. Thank you. Thank you.
Without taking much of time, I'll directly start. First of all, thanks to the Dr. Vasant Dental Academy for giving me this opportunity. Suddenly, before 15 days, I got a dream, like auto running upside down in a road. Auto running upside down in a road. It runs, suddenly a speed breaker comes, the back wheel is locked in the speed breaker, okay, upside down, okay. Then the auto is moving towards a door. Door is getting opening and door is getting stuck in the floor, okay. Suddenly, what you know, the dream gone. Ramesh sir is calling me, Thambi, எப்போ homework முடிக்க போற? Because 15 days before I was zero, exactly, and then Ramesh sir, to be thankful, even though there is 100 sheep in under a shepherd, one sheep gone missing, sir will search for that sheep. He's a good shepherd, so okay, sir. So like that, he called me and he motivated me and forced me. My ODD journey, I am not just going to share my case now. Okay, my ODD journey is little bit different. I started with enthusiasm while in beginning. I convinced some of 2 cases by showing photographs, everything. But I surprised to see that I don't know what to do after convincing the cases. Okay, I did till mock up everything. But the case was the mandible was going 7 mm backward. So I don't know what to do with that case. So I held the case, convinced again another case, and took that case. And also in that case, the patient says, after getting convinced, still backs up. The patient says, I have a habit of biting coconut with my teeth. Oh my God. What will happen if I get into failure? So I held that case. That means pass. Next, I chose another case. In that case, I gave deprogrammer. Patient actually came for complaint of pain in one side, left side of the teeth. I just checked the first point contact. Hit and slide occlusion was there. I gave deprogrammer, thinking that it is going to do some magic. It is going to work. But you know, first one day night I gave, that is a A6 type, overlay type deprogrammer. It worked. Next day, patient coming and saying, sir, now again pain is getting started. I said, wear it like full night, wear it. And then next day I come, it is getting better, but still pain is there. So suddenly I remember Ramesh sir saying, that means whenever your deprogrammer is not working, or if a patient is feeling pain, then it is not under your control, like that. He said, I remembered like this only at that point of time. So I said, you are not under my control, ma'am. You are not my case. So like that I said, so okay, something. What else it may be, like that he said. She said. So I have to check for some other things. I think. The next day, she comes and says what she said was, sir, suddenly I got chest pain. It was a heart problem referring here. Oh my God, just a miss, I escaped. Like that I did. Then 4th case this case I hold it. Is next, that means that lady is next to my clinic only. That is a teacher. So okay, I hold it, go and check and thoroughly come back. I will treat, no problem, like that I told. I finished her case now, as of now. And next case, 4th case, I am getting that case. They came with a TMJ problem. Okay, the same way. But I found that there is a tooth to be treated at RCT, like that, tooth. Maybe referred pain, the one side chewing habit, like that, something I managed to convince. And gave deprogrammer, did RCT, everything. But she tortured me, the pain was too much. Okay. Then after giving deprogram, same dialogue. You are not under my control. So I left her. So I left her. You have to see some other doctor, physiologist. Immediately you have to see because last case the heart problem was there. No. So this case I was forcing her to see a doctor. You have to see. Then she went to Apollo and checked. She had some. That means what is the tumor type in temporalis muscle. Oh my God, what is going on here? Like that, my OD journey was like that. And then I wanted to do some easy cases. I was searching for easy cases from now. Ramesh sir said the same way, as many tooth in our control, it will be easy for us to do the case. So I was checking. That means before convincing this, I used to check which case we should choose. Like that, one case I am choosing. And also, Ramesh sir, I remember in Ramesh sir used to say like some FMR cases with just a feather touch of a burr, you can able to complete. Where is that FMR case? I won that FMR case. I need it very hardly, no? It is the money part. Very easy with the feather touch I can get, no? So I didn't get a case, so yet, sir. And then, as Vasan sir said, some cases are very rare. That means, like, for example, in centric, that means in supine position, when you bite, everything is okay, bite is okay. When you make them stand up, the front tooth gets its no. The cases comes like that only. The front tooth but at that point in time, I don't know long centric, those concepts, that static dot, when they stand up, the forward dots like that, we have to adjust, don't know. But patient came after finishing, completing the front teeth, hitting, vibrating like that. Then only I went back to the lectures and started videos, and then learned, oh my God, everything is there. Why are you researching too much? Shut up and do the exercises. Then I completed some eyes open now. As of now, I am in halfway only, even though I am coming here for graduation. Okay? So pardon me if I have done any wrong in this presentation. I am going on. Sir, I will make it short. 2 minutes only. I'm a little bit nervous too. So this is copied from Dr. Ramesh sir's lecture only. Okay, 7 steps for full mouth rehabilitation. I usually keep it as a Xerox copy of this, and I use this as a reference. And this patient came like this lawyer only. Upper tooth was, everything was okay. I chose this case because I had lot of tooth in my control. Okay, the posteriors I got lot of tooth control. Okay, this is my case like that. So he complains of constant dislodgement of the posterior, this 4, 7 and 4, 8. And I challenged the patient after I removing the crown, if your tooth touches, where is the space gone? I asked the question like that. After removing, the tooth was touched. So he also surprised to see that space. So you have to do FMR like that. I convinced. He accepted. Okay. So now these photos. These are his photos, and all lower anterior tooth are there. So most of the tooth are under my control. I planned, okay, this tooth, this side, most are tooth under control. It should be very easy. Now I prayed, after removing the posterior segment, let all the tooth touch, anterior tooth touch at the cingulum case 1 scenario. I prayed actually. So these are upper and lower photos. Lower arterial and anteriors are there. So it didn't give me permission to share his photos. Face-bow relationship as usual. Mounting after taking centric bite. I'm just sharing photos since everyone knows this already. So and also after seeing SAS lecture 4 lecture, the tap tap tap, the sound was in sleep also there was tap tap tap. In patient also I say tap tap tap. Everywhere it was tap tap tap. Walking also tap tap tap. Okay, the only thing sound I ask is tap 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 only. In that thing, after giving tap tap means static, I forgot to make the patient to do the grinding motions. So then only I learnt the grind. We have to adjust grinding motion at the last also. Okay, in equilibration plate we used to tap 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 and adjust all static contact. But I forgot how to do dynamic occlusion. Then I learned, go back and see the videos. Every time, we learn something, his videos gets more interesting. So now I can sit and watch for whole day also his voice. Sometimes I sleep, but now I now I am watching his voice. Okay, this is equilibration. So first point contact. Okay, I'm just making it in a jolly way. That's all. So in the meantime, I place implants also because patients say, I said minimal invasive way. We have to go for implants. Then suddenly patient accepted, double jackpot. That's all. So I did equilibration these things. As I said, but I wanted, I placed implant, but I wanted to make the equilibration within the enamel itself. If it goes to dentin, then patient has to pay. That's all. So as I prayed for that, anterior canine tooth both I got contacts, and lower remaining tooth I didn't get contact. Now patient gave me a twist. Don't touch my lower anterior incisors. Don't add anything. So he gave me too much. That means trouble. I have to add palatally. It is very difficult for me as of now. So what I did, I made the patient to wait. After finishing graduation, I will come one day. Okay. So these contacts I got after reviewing. So now I did till wax up. So I added everything. Wax up is ready for graduation purpose, but I have to add palatally, as patient said. But lower anteriors I added, and those wax up crowns I have given. So this is pre-op and wax up thing. So very easy case to present. That's why I chose this case. But I am doing as of now 20 FMR cases in hold maybe at finishing stages. Before ODD journey, I used to say Thomas Lassard's quote. He says, a day without endo is a last day. After joining ODD, a day without FMR is a last day. This is how I am going. As usual, the same thing, wax up everything from Ramesh's presentation.
You yourself reading.
So thank you very much as of now. Next, maybe in upcoming graduation, I will be
We'll meet in next graduation.
Good.
Okay? Stay tuned.
Thank you very much. Thank you very much for patiently.
See, the patiently listening, forget about it. Patiently, we have to tolerate him in every way. The thing is, he does everything in his own way. And finally, we'll tell you, it is there in the portal now. Oh, abdiya, sir. Oh, then he'll open the video, then he'll study things, and it's very, very difficult to handle.
Thank you very much.
Because after finishing everything, he has his own protocol. Let me do it. Let me fail. The best part is, all first 4 cases he told no, he would have taken advance for everybody. Yes. Whether it, see, yes.
Actually, some patient completed the payment and waiting, still waiting. I don't know how they are tolerating.
Like we tolerated, no, they are also tolerating. Okay, great. Thank you for this engaging presentation. Okay, give a good round of applause, no? Great. The thing is, he has done all the exercises unknowingly. Seriously, all the clinical cases, he came to my place, I was looking into this exercise. Suddenly he's saying, sir, this I have done, sir. This I have done. Enna exercise? Then only he's asking, what is the exercise? Where is the portal? Oh, portal, oh, video. Oh, you have designed so nicely. 15 days before verdict about ODD is, sir, you have designed so nicely. I should have started from there. That's what we have been telling from day one. Okay. Unknowingly, he tried everything. Anyway, thank you for this wonderful, I'll give the certificate later. Okay. Thank you for that. Okay. So, I'm calling we have another short presentation from our alumni. And they are very proud people because we feel proud about them because they started with zero occlusion to finishing the graduation with the overall award and coming back again to Symposium to present a case to help the academy is phenomenal. Thank you, Divya, for coming. So since we have less time, I just want you to finish on time. Okay, thank you.
Hi all. Actually, before going into my intro, I should say that so far all the presentations, I have seen the documentation is so phenomenal. Even the You know, I used to complain when we were doing the course, sir, the step for treatment planning and articulation has not reached everybody. Something is missing, something is missing. But today I find everybody has meticulously recorded the equilibration in the articulator and equilibration in temporaries. Now I feel my presentation is too less. I think I should thank the mentors for mentoring you all to this level. I think, sir, that sinus lift, that composite addition, everything you taught them in detail, not us. So when I came for the hands-on, for the retake, I found the curriculum itself has upgraded a lot. So you are very lucky. So I am Dr. Divya. I have my clinic here in Chennai. And for me, if you can watch the previous YouTube live streaming of our graduation. My testimonial alone comes too long, so I think I'll keep it short. I was a person who doesn't even like to mix alginate. You know, I had so much of aversion towards all this plaster and all those things. I was a person like that. And even during my BDS, I used to feel whether this profession is for me. I was always in doubts because I couldn't pick up the hands-ons all very easily. And the only departments where I used to be very comfortable is pedo and ortho. Ortho wire bending used to come easily, and pedo, I love kids and I love to treat them. So that is why I did my MDS to become an academician. To become a clinician was never my option till completing my BDS. And then I took MDS pedo with so much of love, and yes, I still love my pedo. But after my PG, I'm putting up my practice, both with general and pedo. And with the general practice, every day was a struggle for me. Every day I used to think, am I doing the right thing? You know, every money which we get from the patient. So I used to think, am I accountable for it? I used to feel guilty. Something is going somewhere wrong. And I took all the blame on myself. You know, sitting in the clinic and feeling not enough as a dentist is something very difficult. And at that time I was working as part-time in ECHS Military Hospital. So I had BDS to take in charge of the morning practice, and that is Dr. Supriya, who has worked with Ramesh sir for almost 5 years. And that girl, whenever she comes to clinic, whenever I come, she used to speak 2 words, FMR, Ramesh sir. FMR, Ramesh sir. Actually, I used to get irritated with that name, sir. What is this girl saying and what is she saying? I was not even getting a clue of... Then I used to tell her, okay, at least you take up the cases, you start to do... It was like totally... I used to think, how could somebody keep on telling that? Then one day what happened, she said, I'm going early today, ma'am, because sir has online class. And that was Sir Seed's class. Then she said, it is free. And then I thought, then you join me also. Let me also understand what you're speaking. And that is how I got an acquaintance with Ramesh sir. And I can divide my professional life meeting Ramesh sir before and meeting Ramesh sir after. That is how I should say. Like ABCD, he brought me into occlusion. And I understood because I didn't know many concepts. That is why many failures were happening. He made occlusion interesting for me. And I understood that occlusion is the basics of dentistry. So when ODD and regarding Vasan sir, I've been to many clinics for consultation. I've met many people. Everybody used to say, Vasan sir, most of the important practitioners in Chennai are Vasan sir students. All of them are gleaming up with so much of achievements. And one word which they will relate to Vasant sir is, everybody who has told me, is ethics, ethical practice. It doesn't come by accident. Everybody says that. So I am very lucky to have been mentored by great legend Vasant sir. And I thank Malar ma'am and Ramesh sir for helping me to reach this occlusion course. Even when they started, I belonged to the first batch. I was saying, sir, I'll join the second batch. I felt I was not ready. But Ramesh sir insisted me, no, you please join. He took that decision for me, and I'm always grateful for that. And Viji ma'am is someone who has been the women behind the screen of the entire Vasant Dental Academy. Even now, in the cases, she keeps asking me, they have finished with temporization. Will the stabilization come? Why that implant is only in the bone? So much, you can't differentiate her that she is a non-dentist fraternity. So much she has learned and helped sir. And we owe you, ma'am, for everything. That happens with every non-medico partner, ma'am, even my husband. So it's like that. So now getting into why I've put this quote, the C is the occlusion. Okay? So this C is so adventurous, but it has given me the freedom to explore my mistakes and understand the concepts and made me love dentistry. Okay? So the case is, so now what is the most important tool will we use for this case? Ortho, right? So this patient came with a chief complaint. No, she's a very known person to me who stays just close by to my clinic also. And her chief complaint was 2-5 caries exposure, palpal pain. But I could see so many dental findings in relation to the occlusal concepts. But that day for the pain, we scheduled an appointment for the RCT, and we went with the RCT. And once her pain all subsided and she was comfortable, I started explaining to her that there are so many things which could be corrected. And her main thing was every 3 months or every 6 months, she is paying for some dental treatment. She belongs to not from a well-off thing, and so for her, spending itself was very difficult. So she wanted a permanent solution. But she was not willing for ortho treatment. And her 3-1 was in grade 1 mobility. And she doesn't want an immediate extraction. She wanted to prolong the extraction. So she asked me if something could be done. So this is the patient information, for the comprehensive examination, which I have prepared. So every FMR patient, I ask my assistant to fill it. As I find it, they fill it. So every muzzle, whatever they teach us is in this. And the summary of this is, TMJ, she didn't have any much of the click or nothing very only just a deviation during closure. Her muscles also only on palpation I could make it tender. She doesn't have any muscular pain or anything. But her dental, almost everything. Okay, she had the occlusal wear, she had gingival recession, her lower anteriors as 3-1, 4-1 with mild mobility, all those things. And her previous restorations were failing. So this is her pre-op photos. So she had non-functional interferences. I felt that both the sides she had non-functional interferences, which made her anteriors very weak. Protrusion also, her 3-7 was an issue. Even with follow-ups during the dynamics, I found interferences developing in that 3-7. During my reviews also, one teeth which was always in a problem was this 3-7, and I had to do equilibration. Okay. So Facebook record, CR bite, articulation. The first point contact matched. So this is the crux of this case. Okay. So whether I can do without ortho, I can't simply promise her. So when we see this picture at MIP, what we see is both the 3-2 and 4-2 are not touching even the palate. So no, that's a happy case. So I need not achieve contact in my centric relation in relation to 3-2, 4-2. Then if you see all the other anteriors, they are almost in one same alignment, no? Except for the 3-2 and 4-2. So without ortho, I felt I can achieve this case. So the equilibration on the model, and this is the mind mapping, the explanation. So what I felt was ortho was not needed, and even sometimes we are in this thing of shaving off all the teeth and making it all look straight. I felt that is also not needed. I will do with the occlusion concepts. I was more minimally invasive thing I followed. So the first visit, mainly her 3-1, which was mobile. So we did a phrenotomy to relieve the pressure, and basic periodontal therapy was done, and then equilibration in mouth with the equilibration plate, then the composite restorations, and we went for the crowns, already 2 crowns in 1617, we removed that, and 25, we are giving a new crown. So first with the provisionals and equilibration of the provisionals, follow up with provisionals for 2 to 3 weeks, and then went for the final crowns and final restorations. Her DASA, imagine with that crowding, how you can give DASA. That was another challenge for me. So I'm just taking you through the procedure thing. So this is her post-op. This is the post-op occlusal. Now, I told you the anterior coupling played the main role. So what happened was, this 3-1, I know this highlighter is not working. So this teeth, during the latrusion, this is the one which is periodontally compromised. So during latrusion, this has to take a great big leap. So I had to compromise on marginal ridge, till at least whatever enamel was available, I reduced it so that 3-1 during latrusion could escape easily, and the pressure on that will be less. Okay, so that was one thing. And even during protrusion, I saw to that only a very minimal hairline contact was, guidance was given by 3-1 and 4-1. Then the 3-2 and 4-2 will come into to take up the guidance. So this is the pre-treatment, and that is the post-op. Okay, and you can see I have also shifted the contact of this 4-3. It was contacting the lateral. So I did an equilibration on the mesial aspect and added composite restoration on the distal aspect, and saw to that 4-3 and 1-3 are guiding. So I was trying to save most of the anteriors and trying to avoid the load on them. So this is the thing. There is a crossover definitely. The canine guided is an end pick. But non-functional interferences, taking photo for her was very difficult. Especially on the right side, the posterior most teeth, I can see it from my eyes, I have given a disocclusion. But to show it in the photo was very difficult for me. I tried it in different angles. I use a mobile only. Might be if I upgrade with DSLR, I could give a better pic. Can you see there also that 3.7, just a minimal disocclusion. That is why I was repeatedly having problem with that teeth. Yes, sir, I have that. Yes, sir. I have that. So this is the post-op protrusive. Can you see 3.1 and 4.1? I just gave a hairline contact. They came front, and the 3.2 and 4.2 are taking up. So see, the dasa, this pic I have taken like this, so it looks a little ugly. Otherwise, the dasa is not so ugly. It is such a crowded anterior. And if you give an S6 and you ask her to remove, the dasa will only extract the teeth. So I had to remove almost the entire labial aspect of the S6 sheet. Then imagine how thin it will be. Then the sheet is going to tear off. So I had to give a platform. I can't just give a cone. I gave a lingual platform of acrylic so that the S6 will be reinforced. And on that, I gave a cone. Why did I give this dasa? Because she's not having any muscular pain or any parafunctional thing. Because I was afraid of that 3.7. Because it was repeatedly giving the interference. So I gave a dasa till the occlusion got settled. I think only the last 3 months, I'm not finding the interference in that 3.7. Every month, I called her for review, and she's the one who will come very sincerely also. So this is just, it was taken on 25th of June, just a few days before the post-op pics of after 1 year. So this is the occlusal markings. After 1 year, I could take a better anterior picture. So you can see in this, I had shifted the canine contact. That is well seen, and how those, this picture is my best picture for this case. Yes. So that is the thing. So what are my wins? Without extraction and without ortho, based on the concepts of occlusion, I could give, I could treat my patient what she wanted. Still, actually I took the IOP of 3.1. There is, the mobility has reduced, but I have only the post-op. That's why I don't, the pre-op was taken in a different system. Because I changed the system, I lost the image. Otherwise, the mobility has reduced and the IOPA looks good, actually, 3.1. So, our mentors made occlusion reach all the common dentists. So, it's our responsibility to make the occlusion concepts reach every common man. It's not that you need a 28 crown case. I think we can do it for each and every one of our patient and do the things. So never get upset if you're not getting your CR by 2 or 3 times also correct. There are many ups and downs, but occlusion-based dentistry is very satisfying. It gives a peace of mind, that is what I should say. So please stick on to it and let us render a genuine service to our patients. Thank you. Thank you all.
Thank you, Divya, for coming all the way and doing this. A perio case handled with occlusion is something we need to learn. Otherwise, straight away we go with the extraction, FPD, we do something. No. So think about it, document. So unless you document, people don't believe your words. Okay. So with this, we are going to go into the next presentation. Dr. Sheeja, another sincere student. Every time my WhatsApp is filled with her photos and her doubts. And all the photos and doubts will be around TMD cases. Okay, I'm planning to send all these cases. With this background, I'm just giving the podium to you, right?
I'm really nervous. I'm sorry about that. This is my case about complete additive case. Thank you, sir. Thank you. Dr. Vasant sir, Dr. Ramesh sir, Dr. Malama for all the guidance. I sincerely thank my mentors, Dr. Vasant, Dr. Ramesh Selvam, and Dr. Malla for their valuable guidance and encouragement and inspiration throughout the journey. I also thank my doctor in the clinic and the staffs for their cooperation and assistance. Special thanks to Dr. Reggie Matthew for introducing me to this course and for my batchmates for their friendship, support, and shared learning experiences. This is my patient case. Her name is Devi. She's 50 years old. Her chief complaint is she wants to close the gap between the front teeth and also to retrude the front teeth. She wants to replace the front upper teeth. She's not able to chew her food properly. The past dental history is extraction of 3/8 and 4/8 before 2 months. Medical history is not relevant. The patient wants to replace the teeth in the front. She wants to close the spacing in the lower anterior. Patient wanted restoration of the carious teeth. She has congenitally missing 1-2, 2-2, and 4-1. Generalized attrition is noted. Proclination of upper and lower incisors, missing 1/8, 2/8, 3/8, and 4/8. The consultation 1, I attended the chief complaints. The restoration was done on 3/3, 3/4, and 1/6. She wanted the immediate replacement of front teeth, so a removable partial denture was placed temporarily for few months. Then basic photographs were taken, basic comprehensive examination of stomatic system done. Patient is also clenching. Then in consultation 2, basic examination shows signs of occlusal diseases in stomatognathing system. Advised her to take up ODBA test. Advised her for orthodontic treatment and implant placement, which she was not ready. Then chief complaint was attended. Then TMJ no symptoms, muscles also no symptoms. Teeth and supporting structures, proclined upper and lower incisors, missing 1-2, 2-2, 4-1. But then her periodontal status was very good. The co-discovery with the patient was she was willing for extraction. She was also willing for removable partial denture or fixed partial denture in relation to missing upper 1-2 and 2-2. She was also ready to give the required time. She was not ready for orthodontic or implant placement treatment. She was willing for ODBA test, and she wanted a minimally invasive and economical treatment. OPG was taken. She was done with the ODBA test details, Facebook records, CR bite. The first point contact was on 2-7 and 3-7. Articulated the upper and the lower cast with Facebook and CR bite. The vertical was at 0 plus mm. Vertical at ICP was plus 0.5 mm. The slide was just 0.5 mm. Then the upper and the lower occlusal view shows full attrition in the lower and anteriors and posteriors. It's a close MIP right and MIP left. The canine is erupted in the place of the lateral in the left side. Then the functional right and the left. Functional right and the functional left shows interference. Non-functional right and the left. This is the overjet and overbite. The anterior coupling was in the case scenario 5. This is a protrusive right and protrusive left. This is the upper and the lower aesthetic view. This is extraoral photos with smile, without smile. Right oblique. This is a close-up view. The first point contact in articulator matched with the first point contact in the mouth. Then the upper and the lower contacts after removing the posterior showed contacts in the both canines. The equilibration chart was failed, but then since I decided to raise the vertical, since the anterior coupling and the ovagite, and I needed a restorative space for the posteriors also. I raised the vertical to plus 2 mm and gave for the to the lab for the VAXUP. This is my equilibration, mind mapping. The lab instructions were given. So I decided to get the occlusal scheme as on the right side canine guided and first premolar group function on the left. This is a criteria for fixing the treatment: vertical, anterior coupling, ovagite and overbite, guidance, anterior guidance, and dynamic occlusion, restorative convenience, minimally invasive, phonetics and aesthetics. The limitations of the case was like a patient did not want orthodontics or implant placement, and it should be economical for her. First, initially, she did not want FPD also. She wanted either Maryland Bridge or RPD, but then I convinced her for FPD. So VAXUP CASFO came from the lab, but then it was not good. I could not get any dynamics or static contacts, which was from the lab. I modified it. I did the canine raise and I added palatal with the composites, and also the lower canines also with the composites. Then I achieved the dynamics and the static contacts. I got the protrusive guidance, right functional, left non-functional, right non-functional, left functional. Then I prepared the index for professionalization. Then the professionals were of the posteriors. I followed the PAP rule, and professionalization of the posteriors were done. Then the anterior relations after the professionalization of the posterior was this. Then I did the professional of anteriors with orotemp. Now I have decided to do the final restoration with the composites through injection molding technique. The missing 1-2 and 2-2 will be replaced as fixed partial danger. Composite veneering was planned on 2-1. The final restorations from the temporization stage will be done by PAPRO. So I did the injection molding technique. I did the injection molding techniques on the posteriors and the anteriors, and got the static contacts. I got the dynamic contacts. Now the right functional and left functional. Right non-functional, left functional. This is a protrusive. Now again the Facebook record was taken, and I prepared the 1-1 and 1-3 and 2-2 and 2-4 for the bridge. I left the 2-1 for composite veneering. Then the Facebook record was taken and CR bite taken, and the models were articulated for the final FPD restoration. I sent the prepared model to the lab, but then I got a very bad temporary. The shade was not matching with the patient's shade. So I didn't get the static and dynamic contacts on that also. So I added the composites on the palatal side and then again did the dynamics and the statics. I got all the dynamics and statics. Then again I took the impression of that temporary and made the model. Then I sent it for making ASICs, and then the fabrication of the FPD was done with the old composite. I heated the old composite and placed it in the ASICs retainer and pressed it inside the mouth, then cured it. And this is the composite FPD. And after 6 months, this FPD will be changed to zirconia FPD. And I have to modify the papilla between the 2.2 and 2.3 later. This is the upper occlusal, lower occlusal. This is static and dynamics cost index achieved. I got the canine guidance on the right side and the group function on the left side. This is MIP right, MIP left. This is the left functional, left non-functional, right functional, right non-functional. This is a face without smile after the treatment. This is a face with smile after treatment. A night guard was given. Patient is asked to have follow-up every 3 months. We'll check the static and static contacts and the dynamic contacts in the follow-up. And this is a happy patient. Thank you. Thank you so much.
Thank you, Sijaji. Good to see a review photo. I have just been waiting from morning. At least one review photo is there. So happy. Always remember, this is more important to build your ODD practice. Can you give a good round of applause? Not for you, not for her, for you to wake up, right? So we have few more presentations. As I told you, I judge this time. This is going to happen. We have informed them. The lunch is not ready. So if you are willing also, lunch is not ready. So, so we don't have an option. Okay. So with this background, I'm going to call another great personality, right? So I am so happy to welcome Dr. Ankit sir. His presentations are really phenomenal. Documentation is to the next level. So you'll enjoy this presentation. Okay? Yes, sir.
Thank you so much, sir. Firstly, gratitude to Vasant sir, Ramesh sir, Malar ma'am, Viji ma'am, to make me capable of like reaching at this stage, and that I can present my case and I can graduate in ODD. It has been a long journey of almost 23 years in my practice now, and I'll like to share a brief of that. So I'm a third generation dentist, so I did not have a struggle of searching for patients. And I did not have a choice also. So like if you have seen Three Idiots, the day I was born, I had been designated to be a dentist. So I joined the course without full heart, but as the course passed, I started developing my interest in the course. And 2003 I passed. By 2005, 2006, I started understanding that occlusion has something to do with dentistry and I must learn occlusion. So I consulted my teachers. They asked me to study Dawson. So I arranged Dawson somewhere. I went through the whole book. Then I thought, okay, I understand. I took up a case. And that case failed so miserably that I had to return all the money to the patient. And somehow I could get myself safe from the legal complications. They was not very common at that time. And I thought that now this is not my cup of tea. So let's do regular dentistry. I'm at peace with that. But that thing was somewhere inside that occlusion is there. I have to learn. So in 2012, I could gather courage again to take up the Dawson book again and read the whole book once again. Understood things better, and then again started with few cases. That time PFM used to be more common. So I had my struggles with that. The contacts opening up, the ceramic chipping off, and started learning one step at a time, slowly. Then zirconia came. With zirconia came the warranty cards. It became so easy. Anything happens, just get the crown changed. But somewhere over the period, the ethical things started coming up. Like patient is already coming with so much of loss of enamel and dentine, and you are giving 28 crowns, damaging the crowns for the teeth further. So that ethics and morals then started coming up. Then I started learning about veneers, about onlays, started practicing that. But still I was afraid of doing FMR with onlays or now. And right now after this, after equilibration and after learning that we can do FMR with composites, it has given me so much of confidence. Like ethically and morally, we are not damaging the tooth structures, and still we are giving so much good to the patient. So this has changed my perspective. It has given a whole U-turn to that. Thanks a lot, sir, for that. So with this, I start my case. Actually, I wanted to speak so much, but there is less time. Yesterday night, sir, talking about. Yesterday night, I had a dream that I am standing on the podium and I am not able to speak. There is no voice coming out of my. I woke up at 4 a.m. in the night. Thank you, thank you. So this is a case, ODD FMR with equilibration and restorations post aligner. So coming on to my patient, let's meet Archana. She is around 30 years of age, a very energetic person, very enthusiastic person. Almost all of you must have encountered some such patients who when enter the clinic, they just lift the mood of the clinic. They'll say hi to everyone, they'll keep cracking jokes, and when they are leaving, they'll say thank you to everyone, bye to everyone. So she was one such kind of patient. So she came, and she is a chemistry teacher in one of the leading coaching institutes, a perfectionist to the core. She wants everything perfect. So she completed her aligners. The teeth looked good, and her chief complaint was that she is finding little discomfort in eating. So she had actually visited our clinic around 1.5 years back with a complaint of spacing in her front teeth. And she had generalized spacing in her maxillary and mandibular anteriors, not a lot, but a little bit of spacing generalized. And according to her, it was a stable and not increasing with time. It was there since a long time, but she could not just get the treatment done. So it was observed that she had mild generalized attrition with loss of anterior guidance, leading to a lot of dynamic interferences in her posterior teeth. And initial photographs were taken, but ODBA test was not done because I didn't know that anything like that exists. This is just before I joined the course. It is around November 2024. So an aligner-based orthodontic treatment was planned to close the spacing of the front teeth. And I told her that because there is a little bit of attritions, so I may need some restorative work later on to improve the guidance. There was no relevant medical history. So coming on to the current situation, the aligner treatment is over, alignment is satisfactory, patient is happy with the cosmetic outcome. Right now, she is on retainers, upper Essex retainers and lower fixed lingual retainers. She did not visit in between during the course of her aligners as she felt that the treatment was showing result as per the plan. And now she feels uncomfortable in eating. She has sensitivity in her back teeth, and she feels that the back teeth are rubbing too hard while eating. So the chief complaint was noted post-aligner ODBA test was planned, a comprehensive examination was done, and patient's only request is to complete the work in a minimum sittings at a minimum cost. And she was hoping that after the aligners, when everything is looking good, so she will not need any restorative work. And she is soon going to get married. So she did not want a long treatment. Case details, the TMJ had no symptoms or sign. Muscles, patient accepts of having some occasional headaches and disturbed sleep, but she feels that it is due to her stress related to her work. And on muscle examination, bilateral temporalis muscles are mildly tender, but no other muscle symptoms. The teeth and supporting structures, the lower anterior teeth have lingual retainers, that is after aligners. And there is a generalized mild attrition in the maxillary and mandibular teeth. Mild crack lines are present in the maxillary and mandibular anteriors. Co-discovery with the patient wants a quick solution. She is ready for a few restorations. She wants it to keep as economical as possible. And she is not ready for extraction. Her 3/8 and 4/8 are missing, and 1/8 and 2/8 are extruded a bit, but she does not want them removed right now. The consequence was told that what can happen in future, and she is ready for it. She does not want the shape of her upper and lower incisors changed, as she loves her current smile. So she specifically says that don't change the shape of the anteriors. Now, after mounting the diagnostic cast with Facebook and CR records, the vertical at CR was 0, vertical at MIP was -3, first point of contact was 2636, and CR to MIP slide was 3 mm approximately. The vertical without posterior segment was -5, so there's a lot of difference, 0 to -3 to -5. The most anterior contact after removing the posterior segment was 1/3 and 4/3, and it was a case scenario 4. And the original vertical of patient at MIP was -3. Now something I would like to add here, which I have not added in the slide, is that when in MIP she was closing her mouth, it was a angles class 1 case. But when I mounted the case and when I at the CR and I could see, it was actually a class 2 case. And I was shocked. What have I done in the aligners? I could not diagnose it properly in the initial stages. I had less knowledge, and now I have done a mess up of the case. So I just went into an ethical dilemma, and it took 1 day for me to come out of it. I just kept thinking about whatever I have studied, and sir, I could find 1 point from your lectures. I could recollect 1 point. You said that when we open the bite, the mandible opens and it goes back. Similarly, when we take the mandible to CR, it goes back and as it opens. So what I thought is if there is so much of a gap from 0 to -5, so that means there is a lot of vertical. So if I do some equilibration, the mandible will close, and as the mandible closes, so it will come forward also. So, sir? Yeah. So it will, as it comes forward, it may go from class 2 angles to class 1, or maybe somewhere near that I will be able to manage. So second day I started on the equilibration on the cast. So now let's come to some photographs. So initial photographs of November 2024 when I started with the aligners. This is the occlusal upper and lower. This is the smile. The MIP bite, and you can see the spaces. These are the spaces that she wanted to get closed. And I found that it is a very easy case for aligners. It would finish in a few months. Post-aligner completion, April 2026. The case got completed in 7-8 months, but as she was a teacher and she has a responsibility, so she did not, it got completed around October 25. She came after March when the students had completed their exams and everything. So she was wearing the Essex retainers, upper and lower. So this is the post-aligner completion, and there you can see that a lingual retainer has been given. Upper was a Essex. The spaces have been closed. She is happy with the current smile. Now ODBA test was done. All the steps were followed as per the protocols. Pre-op occlusal scheme at the MIP position was a canine guided bilateral occlusion. There were functional interferences on the right lateral protrusion and non-functional interferences again in the left lateral protrusion, that means on the right side. Protrusive guidance is normal. In the photographs, I have given only specific, the relevant photographs, not the complete, but I have the full set. So protrusion, that is okay. Right functional, you can see interferences, and right non-functional also, there is interference in the upper palatal and lower buccal cusps. So the equilibration was done on the models. So from -5, the 1-3 and 4-3, I gradually landed up with 3 posterior teeth contacting on both the sides at the -2 mm position. So 5, 6 and 7 on both the sides were contacting. What I felt that I stopped equilibration in the models at that time, and I thought that she is just a 30-year-old. I should not do a lot of enamel reduction because it will damage in the long run. So I'll do some additive work later in the mouth later on. First, let me see how much I can achieve this in the mouth. So I stopped at this position. So equilibration for the initial planning was equilibration for the posterior teeth, establish canine guidance from the CR position, use canines for protrusive guidance to be taken up by incisors later. This is because I was thinking that it was a class 2 div 1 case, so the incisors may not get proper guidance. Incisors may not give proper guidance. So another next plan was to give restorations on the palatal side of maxillary canines and maxillary incisors to avoid changing the shape of incisors, as she did not want the changes. And give an anterior deprogrammer S6 retainer based as a long-term solution and regular follow-ups. So this was the initial planning. The mind mapping. So all the upper anteriors will have palatal restorations and some restoration on 3, 4 and 4, 4, and maybe a little bit on the lower canines on the labioincisal for the guidance purpose. So these are the casts from the first point contact, the 2-6 with the 3-6. From there till achieving 3 posteriors contacting on the molars, and then I started with the intraoral work. It took 5 rounds of equilibration to reach almost equal intensity contacts in all posteriors. Surprisingly, we also achieved contacts on 4 anteriors. There at this point she was tired and I was also tired. So in the next visit, addition was done freehand on the cingulum and mesial and distal marginal ridges of the 2-2 and 2-3 to achieve static and functional contacts. Now this I did freehand because I thought that all the other 4 I have achieved and things are all managed, just I need to do 2 restorations. So I did not plan on articulator and I did a freehand. The patient could immediately feel the change in her bite and she was very happy. So coming on to the photographs, the first point contact, the equilibration plate. Here I learned another thing, that I should make better equilibration plates. Yeah. So you can see the perforations in the equilibration plate because those 4 teeth came into contact. And this is the final equilibration at the end of day 1. So this is at the final stage. All the teeth have functional, static and functional contacts. The close-up of a maxillary palatal view, where you can see the guidance on canines bilaterally, lateral guidance also, and protrusive also initially taken by the canines, followed by the incisors in the later stages. And in the last photograph, you can see the 2 restorations that I have given. This is the only 2 restorations that were needed in the full case. So the closed mouth and open mouth position, MIP right and left sides. This is the post-op photographs, protrusive, right retrotrusive, left late protrusion, So all interferences have been reduced. Now, like I said about the nature of the girl, it was very difficult for getting her photographed in a not smiling position. So this is also where she is smiling a little, and this is the full smile. This is a video of the guidance. So initially it will be protrusion, I guess. No, it's right leg protrusion. Then left leg protrusion. Protrusion. And finally, anterior deprogrammer was given. Sorry for this photograph. I was not there at that day, so my assistant had taken this photograph with her phone. And I could not recall her for taking a good photograph. But this is a Essex-based anterior deprogrammer for long-term nighttime wearing. Thank you, sir. Thank you, sir. The full face smiling view, initial and final. Yes, sir. And follow-up plan is 1 week follow-up. We already had it. Then a second follow-up of 4 months and subsequent follow-up every 4 months. We had some celebrations. We got a Google review from her. And now prayers to God. And thank you to my mentors that I could achieve this. Thank you.
Thank you. Thank you, sir. True minimally invasive case. Okay. We have two options now. Either you watch all the 3 or 4 presentations available, then go for lunch. Or we'll postpone the lunch after 15-20 minutes and we'll finish the lecture. Oh. So what option do you want? Yes, sir, 3 or 4. Okay, anyway. So they are all patiently hearing all your presentation, no? Okay? So it's time that we need to give them, but you can all request them so that we need a short and sweet presentation so that we all go for lunch. Sonika ma'am, please come. Shall I skip 10 slides and then start with 11? No. So sorry. No, I'm just reading the mind wise of people. Okay. Great. Okay. Anybody is hungry?
No one better be hungry now.
Okay. Yeah. You want me to move the slide? I can do very
no,
nicely.
sir, I will do it. So
Okay.
Don't worry. There is not too much.
Hope
to
you
listen
understand
and
my
everybody
situation.
Knows everything now, so I'm not here.
Okay.
To discuss
Okay.
more
Anyway,
the case.
apologize because we wanted to complete sharp by 2:30, but we are trying our level best. There are some exceptions which we cannot. We can start, madam. Thank you.
A very good afternoon to everyone, and thank you to Vasant sir, Ramesh sir, Malar ma'am, Vijaya ma'am for everything.
For all three of you.
Basically, I was not supposed to be here also today. It was only because of one phone call from Ramesh sir as to where you are, and I'm like, okay, I'm lost somewhere in ODD, but I don't know whether I'll be doing it this year or not. And here I am today. So thank you very much. This is a case which I had started very excitedly. He's an old patient of mine. I'd removed a 3/8 and 4/8 for him because they were impacted and they were troubling him. And when I started with ODD, he was the first case that came to my mind because he had started getting attrition also after extracting the 8s. And he comes to me every 3 years, 4 years for a simple cleaning session. The teeth are all good, no complaints as such. And during my ODD journey, he just came in for another session of cleaning. no other complaints, and I noticed that there was palatal wear also in addition to the lower insides of the treating. So I just convinced him, got the ODBA test done and everything. So this is what he had came in with. These are the casts that you can see. I'm sorry I didn't click the pictures earlier. And the face photos, I've not taken his permission yet. The case is still going on, so I'm not sharing them out here now. In these photos, I noticed that there is a midline shift. So after giving the deprogrammer that was, and when I mounted the case on CR byte, so even in spite of giving him the deprogrammer, we decided to just understand whether it was a functional shift or not. So I made another splint for him after discussing it with Vasansa. And after the splint therapy went in for quite some time. Okay, these are the intraoral photos. I'm just skipping through it. This is the ODBA test, just in order to be quick. The Facebook records, the mounting of the upper cast with the record. This is a deprogrammer in the patient mouth. The CR byte record done, mounting it onto the articulator. The first point contact verified onto the cast and the patient mouth. And this was a splint. Once we did the splint, I don't know, something really changed in him, because when I did it on the articulator, 3 hours I spent on the articulator, getting the dots and the lines. The patient, when he came in for the first time, this was my first ever splint delivery, in spite of doing another FMR course about more than 12 years back, but I didn't have the courage to do any FMR cases until this day. So after giving him when I was delivering the splint, I took another 3 hours in one session, but I couldn't complete the excursive movements. I only got the static dots, and I told him, start wearing and we'll do it tomorrow again. The next day again, I took another 3 hours, and he went back home. His wife asked him, were you not tired? Yesterday she took 3 hours, today again she took 3 hours. How did you really manage that? And to my surprise, he didn't give me any gali. He was like, just imagine madam's condition. She was the one who was working on me. So I was like really grateful. And he's one patient who is always happy as to, I'm not understanding what I'm really doing on him, but then he's always fresh when he comes to the clinic. He's never tired now. And just about a month after we, completed with the splint therapy, we are planning the temporaries since a very long time, but then he's having a time crunch as of now. He's a civil engineer and a government employee. Recently got promoted, and I just asked him when he came in, we were supposed to do the temporaries, and he's like, madam, aapko jo photo lena hai, le lo, don't do the temporaries today, because I'm in a rush and I can't really wait. So I'm like, okay. But you're looking very fresh. What has changed? Have you been to a parlor? I really had to ask him. Have you gotten the facial done? And he's like, I don't know, but then all my MLAs and everyone, whoever I meet, is asking me the same question. But something has really changed, and he's really very, very happy about whatever the facial musculature relaxation is. And to this date, where we are is, this was the mind mapping, so I'm just rushing to it. The 8s are missing here. The 7s were the only teeth that had to be equilibrated, and the rest was all a full mouth additive case kind of. In 2 taps, I did achieve the 7 equilibration, and the fillings were planned. This is the wax up. The palatally build-up has to be done, and the lower incisors, as you see. Very minimal build-up in the molars on the lower side. And this is what we have on the articulator. The static dots have all been achieved. Dynamics, I have not done that on the articulator because the wax is weak and it keeps coming off. We are supposed to be doing it very soon in the patient mouth, and I'm really hoping, crossing my fingers, looking at everyone's cases, that this case will really turn out well. Thank you, everyone, for giving me the confidence, particularly the Vasant Dental Academy. I'm really grateful. Thank you. I'm sure this was really quick.
Sonika, thank you, Sonika. You are the best presentation in the entire world. No other person has presented so nicely. So kind of you. So you are amazing, marvelous. You are next to Dawson. Thank you, please. You know my pain.
I want this to be there in the Dental Academy video.
I expect the same amount of love from Dr. Namita. Please come. Where is the presentation, please? And more love from Dr. Madhu.
And hungry.
No problem.
Don't expect that I'm going to keep it short.
Okay.
Because my emotions are flooding and
Thank you.
overflowing. They need to come out.
Okay.
But yes, I can promise the
Can-
case
then I-
presentation will be short.
I'll use the slide changer then.
Yes.
Okay, okay, done.
Okay, I'm Dr. Namita Baheti from Bangalore. I'm going to move on directly to the case. This patient whom we are treating had a chief complaint of jaw pain, which was constant there for past 2-3 years, and the headache she was having after getting up every morning. Plus, she had some disability in chewing her food nicely. She was only 47 years old, and she is a lawyer. So after giving her the deprogramming device on the chair, how many times? Okay, so this is the intraoral pictures. When I saw her, there was not much of the occlusal changes which were there, but then yes, when you see her photos further on, you definitely need to appreciate that there is a lot of palatal wear and occlusal signs which are seen over there. So when I gave her the deprogrammer, she got some confidence that yes, there can be some solution to her problem, because coming to me previously, she had visited multiple specialities where she had also been to a neurologist and ENT where the pain in the jaw was not getting relieved, and she was constantly having troubles with that. With the deprogrammer, she was able to gain some confidence. That's her pre-photos. I'm sorry, this is also become very slow. I can't understand why it's not going fast. So we started the ODVA test once she had some confidence in me. These are her relative pictures. So we, before I wanted to take up the case, I wanted to have a look at the OPG, where you can very prominently see the antigonial notch, yet she had a clenching habit. And before coming to me, she was getting treated in the clinic where they had asked her to take an MRI. So this MRI was actually very old, 3 years old, but then it did say that there was primary osteoarthritis seen in the right joint. So I explained her about the treatment. She was very skeptical, but after giving her the DASA, she was ready to go ahead with the treatment. But knowing that I was dealing with the lawyer and her husband was very nagging, he actually asked me questions more than her, to the extent he got Dr. Bhulabai into the picture. If you know who is Dr. Bhulabai Desai, he is a celebrity dentist. You name the celebrity and he's treated them, right from Deepika Padukone to John Abraham, everybody. And he made me talk to him, just because it seems that he is an electrical engineer and he has done his clinic long time ago. So Dr. Bhulabai wanted to understand how I am going to, take the case ahead. So I had given everything in detail what my mentors had asked me. So even before starting, I had given a proper consent to her that these are the appointments, this is the amount of money, these are the number of appointments you are going to be needing. So all the proper follow-ups was given to her, because what I could see was initially to venture into the treatment itself took 5 to 6 months for her. So I just wanted to make sure that when the treatment is started, I don't want any kind of laid-back attitude from the patient, because when we are having so much of trouble to make sure that she's going to end up in a good function, patient should be equally responsible for that. So we went ahead and did the necessary things. So the pre-op impressions, Facebook record, bite registration, checking in the mouth in the model. That were her pictures. I think you can already see whatever is done. It's nothing very different or a very difficult case. But my journey in this case is quite something which I would like to really share. That is where I just wanted to walk you through this. So when I started the planning, I had to do some understanding of the phonetics and the height of the central incisors. And before I sent up the case to the lab, I wanted to do whatever was taught to us for equilibration before sending it to the lab. So that was the lab, that was the equilibration chart sheet which I was able to put together, where I had decided that there will be restorations in the lower anteriors, and posteriorly the lower arch will get the restorations, and upper I would do composites. So these are the just wax up pictures. This is one slide which I want you to look and remember, and I'm going to come back to this slide later. So this was when I had transferred the temporaries in the mouth. Later on, equilibration was done with the help of equilibration ball, the composite ball in the mouth. That was the first equilibration that was done. Photos of the temporaries being transferred. Patient was extremely happy with the outcome that she had got after I had given full mouth restorations to her, upper as well as lower. And that was the equilibration done again. And this is the transfer which is done, the equilibration which was done second time with the help of the equilibration plate. The bite records. Upper, where I had decided to put the restorations and only composites in the front, and this was during the treatment records, where posteriors were crowns, only the lower arch was crowns, and the lower anteriors were composites. Lab had sent the BIS trial. I have done the BIS trial in the patient's mouth, and I had done the equilibration. Okay, so I'm going to go back to this picture so that you're able to understand what I'm trying to speak. So in the previous picture where I said that there was full mouth restorations done in the patient's mouth, I felt that I have done a good job, and I wanted to now proceed and convert this case into actually doing the ODBA test. But I was not very confident, and especially after doing the transfer in the mouth, the patient had developed pain again in the mouth. The same complaint came back, and I had no clue. Now I had to turn to my mentors to help me with the understanding of that. When I spoke to Vasant sir, the first question that he asked me, Madam, can you tell me how have you decided to raise the vertical, and what made you think that the entire mouth is going to need the restorations? And well, my ODD journey clashed with the opening of my clinic, so I was completely haywire, not at all in sync with the exercises, and I was just listening to the lectures which were happening online, offline, nothing that was happening. Previous to this, I had done some courses which made me feel that, okay, I know something about it, but when he dropped the bomb in me, on me, I was not able to understand how to answer him, so I told him the truth, sir, this is what is the situation. I have not done any of that, and I don't know what to do further. So he said, okay, now go back and take it like a new case. I said, sir, the patient is already paid. I have already paid the lab, and there is already a wax up that has been done. Now I don't know how to ask money from the patient. He said, that's okay, you have a wax up. Take that wax up, put it in a bucket of hot boiling water, remove the wax up, take this like a new case, and now do everything that you know. So from there, I had to go back, remount the case. I made sure that I get the equilibration dots at least on the posteriors, and from there, I was able to decide the vertical. Once the vertical was decided, I could come to the conclusion that I need to only restore a few teeth in the lower arch with the permanent crown. Upper can get away with the fillings only. And because the lower anteriors were attreated, I can get away with composites because her lower anteriors were not aligned well, and they were the ones which were actually very small and attreated. the uppers, she was showing some palatal, she had chronic acidity issues, so she was showing palatal erosion, which is why I have decided for veneers for the upper anteriors and lowers would remain as composites. So that is where this case is till now. After this, the BISC trial is already done. Now what is remaining to be done is to, sorry, I'm going back. What remains to be done is that I just need to put the final in the posteriors, and once the final is done, I would want to take an impression of the upper and lower temporaries, the upper temporaries especially, so that the lab can duplicate it for me while I make the preparation for the veneers. And once I'm able to cement the veneers, I want to do the the composites, freehand composites in the lower, and I want to give her a dual arch overlay type of a retainer so that her problem of clenching can be resolved. And I have already explained her about the follow-up, wherein I need to see her after 1 month, 3 months, 6 months, and 1 year to check her hygiene and to have an equilibration corrected in the mouth. So that was my journey here. I would just like to thank you, Vasant sir, a lot, because he was my guiding light. No matter the hour or the continent, he was there every step to help me. I had called him in hours where other people would literally groan, but then he was there every single time, and whenever he was not able to be there, he used to message, I'll get back to you. And I really am very awed with the experience, the patience, and the calm advice which he handled me with every single time, and he became my anchor in the toughest moments. And about my other mentors, Malar ma'am and Ramesh sir, what can I say about this remarkable couple? Friends who redefine dedication. They help without hesitation and cross all the boundaries to help you wherever you are getting stuck. With their hearts filled with generosity, I have felt every single time that they have given you a lot of knowledge and support. I've learned not just from their genuine, from their expertise, but their genuine kindness in every step. So I will be very proud in saying that Vasant Dental Academy has not only made a better clinician out of me, but also a better person. Thank you all.
Thank you, Namita, for the love.
Hope it was according to your expectations.
Thank you.
Sure.
You finished almost on time. I'm happy about it. Okay. Thank you for that. So next I'm going to call, come Madhu.
Closing this event with the presentations, I'm going to make it very, really short.
Telling lies.
No, I'm not lying, because there's not much to talk about. Yeah. No, it will be less than you. So I would really love to take this opportunity thanking Sir Ramesh sir, Vasant sir, and Malar ma'am. Malar ma'am goes unnoticed many times, but she is the one doing all the hard work, and I think we all owe it to her. It is her who does, it is she who does the presentations, and really the backbone of this academy sometimes. So thank you, ma'am. And thank you, of course, Vasant sir and Ramesh sir. That goes without saying. The knowledge that they have imparted is commendable. And a word like thank you seems very small, to show our gratitude towards them. So I'm still taking baby steps in this journey. I'm a periodontist. Like many have said, they hated alginate, they hated plaster. I'm one of them. So I can relate very well. So I'm still taking baby steps, and this is how I have executed this wax up and articulation in the articulator for this case. Okay, so this is a very simple case where the patient came with, where this was done with restorations and equilibrations. So this patient came with a chief complaint of attrited lower anteriors the restorations were done in the lower anteriors because she had sensitivity, but they kept coming off. And she had a few posterior restorations as well, and those two kept coming off over time. And she was a patient who had already had ortho treatment in her teenage, and there was chipping of her lower incisors, which was noted. She also had severe headaches and neck ache. So on palpation, the sternocleidomastoid, the splenius capitis, the masseter, and lateral pterygoid muscles showed pain. One minute. Yeah, sorry. So the occlusal scheme for this patient was, there was tooth guidance with 1.3, 1.4, 1.5, and anterior guidance with 2.3 and 2.4. And there were functional interferences observed in her mouth. So first the patient was, the ODBA test was done, wherein impressions were taken, deprogrammer was given, and that's how the link was established, wherein she understood that the occlusion played a major role in causing these fillings to come off, and also the pain in her neck and in her head. So this patient, since she had already undergone orthodontics in her teenage, she was not cut out for further orthodontic treatment. So she gave us an approval for equilibration and composite restorations. So this is how she came to us. This was her MIP frontal, and you can see the incisors chipping off in the open bite view. And this is how her bite was. And this was her lateral and left lateral, MIP left lateral and right lateral. And these are the occlusal views. And so these were the excursive movements. And we could see some interferences in some of the movements. So these were the extraoral photographs which were captured. Face bow was taken. It was transferred, and a deprogrammer was given. CR bite was taken. And the first point contact was seen in the palatal cusp of 1.7 against the mesiobuccal cusp of 3.7. The lower cast was articulated with the CR bite record, and mind mapping was done, wherein we plan to do only equilibration with the marked teeth and composite restorations with the lower. So the equilibration chart sheet was executed, and we noticed that we managed to get contacts with most of the teeth except a few. So I'm just going to skip it because we don't have much time. So the equilibration was carried out, and what we noticed was we were not getting static contacts with the lower anteriors against the uppers. So composite buildup was done in order to get that. And also between 1.5 and 2.4, there were no contacts. So landing pads were created in order to get the static contacts. And also the guidance was achieved. In the dynamic movements, we decided to give canine guidance on both sides. And in protrusion, 3.1 and 4.1 were planned for taking up the guidance. So the wax up was done, and it was, till this stage, I have executed in the articulator and planned. So this is a picture showing the landing pads created on the premolars, and the canine, the addition of composite on the canine, on the palatal of the canine, so that that takes up in the canine guidance. Also, the tip of the canine was a little off, so we added a little bit composite there, so that it looks a little more, angulated in the right angulation. So this was how the static dots and the static dots were created on all the teeth, with the guidance being formed with the canines and the lower 3.1, 4.1. So the same thing is going to be executed in the mouth by creation of a equilibration jig, and verifying the first point contact, and then the same process as what everybody has discussed. And then we do provisionalization by means of pro-temp temporaries. Again, do the equilibration and attain all the static dots on the temporaries, check the dynamic movements, fix the occlusal scheme, wait for 2 weeks, recheck the dynamic and the static movements, and do the finals with composites on the anteriors with the help of silicon index or a lingual index or a direct buildup. And then after that, the patient is advised to wear DASA at night time only, and a periodic recall of 3 to 4 months is advocated. So I kept it really short. Thank you.
Thank you, Madhu, for this. Okay, so happy? Hello, are you happy, Madhu? Can you hear me? Do you know how much sacrifice these people are doing? Okay, right. So here comes the final vote of thanks and final talk. Okay, right.
Very good afternoon to one and all present here. I'm Dr. Monica, ODD Stomach Nothing Specialist. I'm very proud and happy to share my ODD journey here. Looking back, it is one of the most transformative decisions in my clinical practice. What started as a desire to improve my clinical outcome gradually evolved into a completely different way of diagnosing, treatment planning, and also treating the patients. So I would like to share how ODD practice changed my practice, and also it made me to stand out of the crowd because I always approached every patient with an occlusion eye. So before ODD, I was treating more teeth than the patient. Complex cases, sometimes the simple cases also felt challenging, and I was uncertain about occlusal diagnosis, and I always wanted predictable and long-term outcomes. So instead of what, I was always looking for why. Why did the restoration failure? Why did the patients are having muscle pain? So this shift from treating symptoms into identifying the root cause completely changed my clinical thinking. So what changed in my practice? Tooth-focused treatment becomes patient-focused, and the basic examination turned into comprehensive diagnosis, and limited records moved into a complete documentation, and uncertainty became my confidence. So my ODD workflow changed the way I practice. So after ODD, I started a systematic flow of following the patient. So every patient starts with a complete evaluation followed by photography and records. And with the records, I do occlusal analysis or ODBA test. So with that test, I will come into a diagnosis and a more predictable treatment planning. And it's also patient-centered. So this was my best, one of the clinical transformation happened. Yes, the ODD journey was exciting, but it always was challenging. So understanding the occlusal concept and analyzing the functional problems, mastering the treatment planning, repeated learning, and also applying the ODD protocols into the practice was challenging. But I always decided to trust the process. And so when I started applying the ODD protocols, I believed if I explained the treatment plan correctly to the patient, I thought every patient would accept. But in reality, it was different. Most of the patients listened to my treatment plan, but they never turned back. Some patients accepted, but cost was a barrier. So I was always wanted to learn more about how to communicate in a better way and how to educate the patient and how to help them understand the value behind the treatment. So after doing many ODBA tests consistently and after visiting SIRS clinic, I gradually learned how to communicate with the patient in a better way. As my communication improved, I found 3 types of people in my practice. And this is what our mentor says exactly happened in my practice too. One group usually accept the treatment because they understand the treatment, so we started the treatment immediately with confidence. The second group of people decided not to continue the treatment and went to some other clinic. 2 of my FMR patients came back to me with the problem in the treatment they received for the correction. This gave me really a confidence that a well-planned ODD truly makes a difference. And the third group of people, they genuinely wanted the treatment, but they couldn't afford it at that moment. So they took some time, arranged some finances, and came back to me because the trust I gained from them. So ODD is not just about occlusion and treatment planning, it's also about communication, consistency, and trust, and also the patience. So when the patient understands the why behind the treatment, They didn't accept the treatment alone, but they accepted me as their dentist. The second obstacle I faced in my journey is my articulator. Just before my graduation, one of my patients accepted the treatment. When I was about to start the treatment, I faced a problem with the articulator. So I approached the sir again. He advised one thing, to invest in Artex. This obstacle didn't stop my journey. Instead, it upgraded my armamentarium and improved my practice too. The third one, this is not more of obstacle, it's more of transformation only. After applying ODD protocol into my practice, I started noticing gradual decrease of my patient flow, but didn't affect my clinical finance. Instead, surprisingly, it increased my profit because I was offering a higher value and more comprehensive treatment to the right patient. And the patient also started realizing the quality of the treatment, and also they became more comfortable with a higher level of satisfaction. So the biggest learning is successful dentistry begins with the diagnosis. So 80% is the diagnosis and treatment planning, and the 20% is only the execution of the plan. So ODD taught me to slow down during diagnosis and understand the function in a better way, and to plan predictably and delivering long-lasting dentistry. So the impact after ODD is better diagnosis, higher treatment acceptance, more confident in complex cases, improved patient satisfaction, and also better referrals. So after ODD, in my treatment procedure, whether it is direct, indirect, or ortho treatment, I started seeing more successful in the outcome. And of course, one of the biggest advantages is the guidance. So continuous learning even after the course. And the learning didn't stop with the graduation. Actually, it improved my learning process. So our case discussion in WhatsApp, an alumni webinar, and continuous mentorship from our mentors, and of course, clarification of the simple to complex doubts among our various batchmates during office hours helped me treatment planning in my everyday practice. And connection, another fortune of the ODD journey is connection with the lovable batchmates, my batchmates, and after taking seminar with other batchmates, peers batchmates, and BioClear alumni. They are from different subjects and they're having a diverse background in dentistry, helped me in learning many things, and also to gain valuable insights. So this ODD, I'm thanking ODD for sound connections and meaningful network. And this is my practice of about 200 square feet. And I have almost completed 40 plus ODB tests and 3 FMR cases, and 19 plus FMR, including ortho treatments, is ongoing. So this higher level of acceptance nowadays pushing me to come out of this single chair practice for the expansion now. With the blessings of God, wholeheartedly I'm grateful to my mentors and my clinic team, my family, and also my patient for having trust with me. ODD is just not a course, it's a mindset. It made me to sleep better every day nowadays. It taught me to see beyond teeth, understand function, and create treatment plans that are predictable, stable, and also patient-centered. So my ODD is a never-ending journey. I will keep on learning for my growth, and I'm ready to face challenges and accept the lessons. And I will work always best to receive the best and also to deliver the best. And thank you so much for the wonderful opportunity.
Thank you, Monica, for this wonderful presentation. As if she is working like a public relation officer for the ODD course. Okay, so seriously, I didn't even see what slide is there. This is first time. This is something comes from heart, no? So happy. Here comes the 100% Idamba final, Mahendran. Pradeep, you can believe that this is the final, okay? So thank you for all the wonderful presentation. So with the presentation, you have made a lot of hard work to do this. It's not easy. Living all the practice, doing everything, and coming and spending time here is not easy. So happy to have you all for the symposium. My sincere thanks to you and your family especially. Because without your family support, I don't think you will be able to make it. Okay, so all those people are the angels whom I see, right? So the moment you become a part of our ODD family, your thought process will change for life. Believe me, don't stop with this. People who have continued are like this. 30 FMRs in graduation itself. Think about his numbers after the graduation. So Monica is one of the phenomenal students. So she wanted to achieve. Okay, she was directionless before joining ODD, and she was almost like she wanted to be a part of ODD. Okay, that is how the journey started. Okay, so what is so special about ODD? Can you say in one word? You don't want to say any word. Lunch only you will say, I know that. Apart from lunch, one word? Yes, sir. Okay, super. Next. Ethical dentistry. Any other word? Great. Give a good round of applause. No? Can you say one more word? Gratitude. So we have tried as mentors, sir, ma'am, me, Malar, and the entire team. So it's not a one-man job. Okay, there are a lot of people who are behind the screen who have been working tirelessly for you to do all this job. So every single, from chair to paper to presentation, it's not easy. It is very, very tough. I need to thank everyone here. Of course, I need to thank my occlusion guru, Dr. Vasant sir and ma'am, for this incredible journey, because he started my intuition, my journey in occlusion, which I will never forget in my life. Okay, special thanks to my guru, next to God, thanks to my guru, right? Next comes the every audio people, video people, especially I have to put a good round of applause to Sam, because believe me, this time he has done more job, and we have been torturing him like anything, literally torture. Okay, like how you do me, how you do that to me, no? So more than that, because finally he'll finish one final, okay, this is okay. Is it okay? I'll immediately say, you have to put Shruti Goyal in the bottom. That picture, she has to be here, because I wanted to be here, highlighted separately from the other batches. I wanted that to happen. Do you know how much time it takes to change that entire perspective? Like that, I have tortured enough. Okay, thank you, Sam, for this wonderful thing. So, of course, I know I don't have to say anything. So, about occlusion, believe me, occlusion will take you to the next level. Your confidence in dentistry will increase like anything. How many people are very happy being a part of ODD family? Can you all clap your hands and say that you are happy? So I want to just conclude this with a small video. With that, we are going to conclude the ODD Symposium. Clear? Shall we? So we face many challenges in dentistry, right? Do you know how I felt when I learned occlusion? Exactly the same way. You'll see that, right? So when I learned occlusion, there are a lot of challenges which we face in dentistry, correct? That crown doesn't say, this ceramic is chipping, that composite is falling. All simple things, but we don't have a solution. But the moment you understand that you are a master of occlusion, the exact feeling what I had is what I have put here. Okay, so let's see and enjoy the format. Okay, right?
இப்போ புரியுதா நீ யாருக்குள்ள ஆள் அனுப்பிச்சிருக்கன்னு? காரு வர சத்தம் கேக்குது. ஜெயிலர் வந்துட்டாருன்னு நினைக்கிறேன். நல்லா ஒத்துப்பார் செங்க யாருக்காக ஆள் அமைச்சிருக்கான்னு தெரியும். அவருக்கு அகேன்ஸ்டா எவனும் வரமாட்டான்.
Okay. Just to finish this on a good note. Okay. So believe me, the moment you know occlusion, this is how you'll walk into your clinic. You won't care about number of patients. You won't care about only one patient. You won't care about small things. You won't fight for root canals. You won't fight for all those simple things. You know one FMR can pay you the satisfaction, the money, the fame, everything. So we are the Rajinikanth of dentistry in India, right? Okay, thank you. With the note, we conclude here. Please go have your lunch. Sharp by 4:45 to 5 o'clock. Please be here. Once again, sir, please come. Once again. Just 2 minutes, you just collect the certificates and go because definitely we are going to miss. Sir, please, 1 minute, ma'am. Ninga vaanga, ma'am. Yeah, please come. It's okay, don't give me a direction, Sonika. Just obey what I say.
Next, Dr. Lakshman. Dr. A. Stalin. Dr. U. Tachiani. Dr. Madhu Brida. Dr. Mahendran. Dr. Dr. Shivla. Dr. Meena Shah. Dr. Venkatalakshmi. Dr. Uma Maheshwari. Uma Maheshwari, she's coming. Dr. Namida.
Dr. Ankita. Dr. Prateet. Dr. Ankit. Dr. Sauda. Dr. Sharmila. Dr. Reggie. Dr. Shija. Dr. Sarida. Dr. Soniga. Dr. Vipin Das. Dr. Hemani. Dr. Ishwari. Dr. Shushmita. Dr. Monica.